Hello, everyone. We'll be getting started in just a moment. We're admitting people to the Zoom right now. Thank you for being here. Oh, we've got an excellent group of participants joining. Great to see the numbers going up. I think in the interest of time, we'll go ahead and get started. So I'd like to officially welcome you to the Family Planning and UHC Agenda second collaborative dialogue on the nooks and crannies of UHC policy implementation. Where does FP fit in? My name is Amy Baldasser-Bush, and I have the pleasure of serving as your moderator today. I am a Senior Director at Management Sciences for Health, where I lead our work on health policy advocacy and engagement, as well as integrated healthcare. I also oversee the work of the Secretariat of the Civil Society Engagement Mechanism for UHC 2030, which is the global multi-stakeholder partnership working to achieve universal health coverage and strengthen health systems. The Civil Society Engagement Mechanism and our more than 800 member organizations in 100 countries advocate for UHC policies that are inclusive and equitable to ensure that no one is left behind on the road to UHC. And we're delighted to be a part of this panel today. We have a fantastic group of panelists, and we're very pleased to have all of you here to join the conversation. Next slide. Before we begin today, a few reminders about today's webinar. You'll also find that information in the chat. The webinar is being recorded, and we're pleased to be offering simultaneous interpretation in English and French, as well as access to closed captioning. All participants can select their preferred language by clicking on the globe icon at the bottom of your screen. When you do, you'll see the options for the English or French channels. To mute the original audio, if it's distracting you from hearing the interpretation, select that option. Everyone does need to select a language today to ensure that you'll be able to hear all of our speakers. We will have presenters speaking in both French and English today. If you need any support with the interpretation or other features of Zoom, please let my colleagues in the chat box know. In addition, you can also select today whether or not you'd like to read captions during the session. You may be seeing them automatically, but if you're not, and they would be helpful, click on the icon at the bottom of the screen, including 2 CCs. I'd like to thank our partners for today. We can move on to the next slide. I'm not actually sure if the closed captioning is enabled. Let us know if anybody needs access to that and it's not visible. There it is. Okay, great. Sorry. So you can click on those 2 CCs that are marked live transcript. If you wish to hide those captions later, you can select the icon again to turn them off. I do want to note that the captions are automatically generated by Zoom, so there may occasionally be errors. And on the Zoom platform, unfortunately for now, we can only provide those captions in English. Okay, now on to thanking our partners in this series and our co-hosts, FP 2030, Knowledge Success, PAI, and to thank our speakers who I'll be introducing to you shortly. The co-hosts are all standing by to collect your questions and comments in the chat box, so feel free to enter them at any time during the discussion, and we'll do our best to answer as many of them as possible. So as I mentioned, today is part 2 of a 3-part series on family planning in the UHC agenda. And the timing of this dialogue series is important because it's providing an opportunity for all of us in the family planning community to come together in these interactive discussions in advance of the International Conference on Family Planning, which will take place in November of this year, and which will have a focus on family planning and universal health coverage. The conference itself is also an important moment in the lead up to the second high-level meeting on universal health coverage, which will be convened by the UN General Assembly in September of next year. I wanted to mention that this dialogue series and your participation here will contribute to the development of a policy paper on family planning and universal health coverage, which will outline policy priorities and key advocacy messages that we can use in the lead up to that high-level meeting. We'll be sharing a draft of that policy paper for validation during the International Conference on Family Planning, and we'll be releasing it officially on International UHC Day, December 12th. So we hope you'll help us to amplify that as well. If you missed the first dialogue, it was a great conversation on efforts to shape policy and mobilize civil society to help ensure that those commitments to UHC and family planning become a reality. Don't worry, it's available on the Knowledge Success website, and we'll share the link for that if you want to review that webinar. I really recommend taking a look. We also hope you'll join us for part 3 in this series, which will be coming up on October 18th, where we'll talk about the importance of leaving no one behind in achieving UHC and universal access to family planning. Today's session will be a treat. As I mentioned, we're here to talk about UHC policy implementation. So we're moving from the policy design discussion to talk about what's needed to implement the universal health coverage agenda. And our fantastic panelists will introduce the various financing models. If you can move to the next slide, actually, ladies. The panelists will be talking about various financing models for achieving UHC and discussing opportunities for integrating family planning. We'll also talk about how to amplify best practices and programs to expand access to FP services. And we'll talk about the role that all stakeholders, including public and private sector, play in realizing UHC and fostering innovations that prioritize family planning. So the plan for today is that I'll pose a few questions to our panelists, encourage them to dialogue a bit with each other, and then we'll open up for questions and comments from all of you, which we'll be collecting from the Zoom chat. We'll have plenty of time today to include you in the discussion, and then I look forward to some closing remarks provided by Nabiha Kazi-Hutchins, the President and CEO of PAI. Next slide. So please join me in welcoming our panelists. Can somebody bring up the panelist slide? Thank you. Who will be joining us today and speaking. Thanks to all of you for being here. We're looking forward to engaging with you in the discussion. I'll provide a brief introduction to each of them now. Our first speaker will be Dr. Dine Fadima Kaba, who is the National Director of Family Planning and Nutrition at the Ministry of Health and Public Hygiene of Guinea-Conakry. She's a specialist in pediatrics and a public health physician with extensive experience in maternal child health and nutrition, having previously also led initiatives for JPIGO, UNICEF, and the Ghanaian National Institute of Public Health. She's also an assistant at the Faculty of Health Sciences and Technology and chair of pediatrics in her country. Thank you for being here, Dr. Kada. Our next speaker will be Matt Bakshal. Matt is a program director at ThinkWell, where he leads a portfolio of work focused on strategic purchasing for primary healthcare, supporting strong local teams to deliver high-quality technical advice in 6 countries in Asia and Africa. As a senior development professional with more than 20 years of experience in global health and reproductive health and rights, Matt has designed and led innovative programs with global impact and worked closely with governments to steer national policy. Matt provides strategic leadership to senior technical advisors and country directors at ThinkWell and works with the wider global health community, particularly on issues around financing for family planning. We also hope to be joined today by Dr. Brenda Frey, who's the Deputy Director at IHAT with the Government of India. We are experiencing some technical difficulties with her joining the conversation right now, but I will introduce her when she's able to join us for the conversation. And our final panelist is Dr. Ben Bellows. He's co-founder and chief business officer at Nivi, a consumer-facing digital health company offering a marketplace where empowered individuals navigate health resources via Nivi's goal-oriented chatbot experience. Prior to Nivi, Ben was a health services researcher at the Population Council, conducting studies of performance-based financing, reproductive health vouchers, and health policy with government and non-state partners in sub-Saharan Africa and Southeast Asia. His lifelong work and extensive list of peer-reviewed manuscripts covers healthcare financing, human rights, and reproductive health. Thanks again to all of you for being here, and great to see all of the participants introducing themselves in the chat. We have a great large group this morning, so let's get into the conversation. If you can bring the panelists up to the screen, I will start with a question for Dr. Kaba. Give the team a moment.
If Dr. Kaba could please turn on her video, that would be great.
There we go. Allez, ça marche.
Vous m'entendez?
Oui, très bien. Yes, we hear you
Can you
very
hear me?
clearly.
Yes.
Ok, merci beaucoup. J'ai le redoutable honneur
Thank
de...
you very much. And it is an honor to be the first one to speak and respond to the first question. Thank you as well for giving me the opportunity to talk about a subject that is a very important and serious concern. This is something that is very important for the Ministry of Health. In terms of best practices, Guinea has started on the path towards UHC in focusing on primary healthcare. Primary healthcare is the first step, and in establishing a national policy and national strategy, and looking at community health as well, we have learned that it is very important to work with community health workers to make sure that they are trained in official institutions and to learn how to provide primary healthcare services. But we need to work with these groups and people that are within the community, and then we can integrate these services, including family planning services. So these are preventive services and also other medical services. So community health centers and community health workers are a way to provide these services at the community level, and we can give them different tools, including DMPA, SC, and other contraceptive methods, condoms, and we can also work with them to develop awareness campaigns in order to create demand at the community level. Currently, we are working on women's empowerment initiatives, empowering women to use self-injection methods of SCDMPA. We are seeing more women who are using this molecule. And we think that if we can work at the community level, then this is truly a way to bring services to a greater number of people and to include people who need this care the most.
Beyond this, for primary care, we continue to be thinking about to see how beyond healthcare for human beings, how we can cover the financing of family planning services at the secondary and tertiary level. So this is, for us, the path adopted by Guinea to go towards UHC. We are at the very beginning, at the starting point. There are a number of steps and milestones towards which we are moving in order to ensure that universal health coverage becomes a reality. Indeed, family planning must be at the heart of this initiative, which aims at leaving no one behind. Guinea, I believe, is ready, and this can be seen through everything that is currently done in terms of family planning and promotion of the broadening of the means of contraception means that are available at the level of primary health, at least. Thank you.
Thank you very much, Dr. Kaba. And you've touched on a number of important themes that we're going to talk about today. The importance of engagement of health workers at all levels, including community level, to advance universal health coverage and access, including to the most hard to reach populations. You've touched on the importance of financing, which we'll be moving on to with some of our next panelists. And I think also that, you know, highlighting that there is a road that it takes time to achieve both the goals of universal health coverage, as well as seeing truly universal access to family planning and reproductive health services, but the important strides that countries like Guinea are making on that path, and the importance of ensuring that family planning is at the core of universal health coverage. So thank you for starting us off with those very important comments and perspectives from the ministry. Looking forward to hearing more about that in the discussion. I'm going to pick up on the point that you made about the financing, looking at the opportunities for supporting both primary health care and broader universal health coverage packages by moving on to Matt. Matt at ThinkWell, you certainly bring extensive expertise in the work on financing of family planning. And so I wanted to invite you to talk a little bit with us today about what you've seen in terms of innovative people-centered financing models that can potentially provide sustainable resourcing in the context of diminishing donor resources, COVID-19, cuts to budgets. This is certainly at the core of many of the FP 2030 conversations now. So over to you.
Thanks, Amy. And yeah, it's a great question. It's a tough question, and it's a huge challenge. Broadly, I'd suggest that if we're looking for the right solutions to finance family planning, there are a few things we need to bear in mind. We need to take a system-wide perspective. We need to spend money as efficiently and effectively as possible, the money that is available. And we need to focus closely on who will benefit from a particular financing scheme. But beyond those very broad principles, I think any solutions will depend enormously on context. So I'm going to be drawing on the amazing work that my ThinkWell colleagues are doing in countries from the Philippines to Burkina Faso to try and give some of that sense, and I hope that I can do them justice. Let's start with family planning. I don't have to convince anybody on this call that investing in family planning is the right thing to do. And there were some great discussions in the last session about the fact that it's a smart thing to do as well. It makes great economic sense. Sustainable, targeted investment is essential to ensure that those most in need have access to a choice of quality family planning services. And the investment needs to cover promotion as well as service delivery, and it needs to reduce financial barriers to access. So when we talk about financing any health services these days, and especially when we talk about removing financial barriers, we inevitably find ourselves in the context of UHC. The idea that everyone should have access to the healthcare they need without suffering from financial hardship is powerful. UHC has become a rallying cry for us all. And there can be no doubt that investing in family planning must be at the core of UHC. But we must remember that UHC is a goal. It's an aspiration that we are striving towards. We'll only progress towards the goal of UHC by looking at health systems as a whole and by considering all the sources of financing that fuel the health system. There will be many. And so it's important to emphasize that UHC is not about a specific health financing scheme or even a specific approach to financing health services. To imply that is to confuse the goal of UHC with the means that we use to achieve it. We need to be particularly careful with national health insurance schemes, sometimes branded as UHC schemes, and those that require premium payments to access benefits. According to a paper published last year by our colleagues at KEMRI in Nairobi, there's only 4 countries in sub-Saharan Africa where national health insurance schemes cover more than 20% of their population. There's an underlying problem. It's proved very difficult to use national health insurance as a mechanism to use premiums paid mainly by formal sector employees to subsidize services for the poor. I think this is a really important lesson for the many countries who are considering setting out in that direction, like Uganda or Burkina Faso. And it's an important piece of context for us as family planning advocates, seeking to direct resources to those most in need. Including family planning in a benefit package will not help those who are excluded from an insurance scheme. So to come back to the original question, how can we tell whether a financing scheme is a good choice to provide sustainable resourcing for family planning and to reach those most in need? The first question I would ask is, who will benefit from the scheme? If a scheme specifically targets the poor and does not link benefits to contributions, it might be a good choice. Kenya's Linda Mama scheme is a universal entitlement for all pregnant women funded by government revenue, not by premiums. And there is a great opportunity there to work with Linda Mama to include and encourage the offer of postpartum family planning through that scheme. In Burkina Faso, the Ministry of Health is showing how this can be done by using general revenue to pay providers directly for family planning services that they deliver free of charge through the Gratuite program. These schemes both avoid the trap of linking benefits to premium payments, and so they have a good chance of reaching those most in need with family planning services. They focus on spending general revenue more effectively, and that's a good place to start. But if we are looking to raise additional money, Ghana's NHIS might be a useful example. The National Health Insurance Scheme in Ghana is working hard to enroll the poor, and most of its income comes from a levy on VAT, raising progressive taxes through general government financing. Or we might look to the Philippines, where the government raises enough money from sin taxes on tobacco and alcohol to pay PhilHealth premiums for more or less half of the whole population of the Philippines. To summarize very quickly then, finding good ways to finance family planning services should start from a system-wide perspective, should look for ways to spend money as efficiently and effectively as possible, and critically should identify financing schemes that are the most likely to deliver services to those most in need. Thank you, Amy. Back to you.
Thanks, Matt. That was brilliant and clear. A very complicated set of concepts around financing for universal health coverage, broken down, and I appreciate the use of the country examples. I hope that perhaps some of our participants who are joining from countries that have been experimenting with these different approaches to providing sustainable financing for UHC will comment or pose some additional questions for you on how that's working where they are. I also really appreciate the focus on, which is leading into the discussion we're about to have with Ben about sort of reaching those who are hardest to reach and understanding that those that are outside of formal systems may often be left out from those social health insurance type programs. Thank you very much. I'm going to turn to Ben now. to continue a bit on this theme of access and innovation. NIVI obviously has a strong, as a platform and an organization, a strong focus on innovation. And so I'm looking forward to hearing from you about some of the most innovative tools or approaches you've seen for ensuring that we really enable access to health services, including family planning, to the most left behind. And we can see your slides very clearly. So go ahead, Ben.
Great. Okay. Well, thank you, Amy, and thank you for the opportunity to speak with all of you. It's a wonderful opportunity to come together as a community of practice and share some insights and have a discussion on this important series of important questions. I would start with first suggesting that there are certain attributes in any innovative approach that we might want to avoid before we get into what we want to focus on. I think in any innovative approach that ensures access to family planning, we ought to avoid duplication. We ought to avoid fragmentation, avoid process at the expense of outcomes. And of course, as Matt's already alluded to in the financing question, avoid excessive out-of-pocket cost so that all of us can truly benefit from the resources being made available. Where does that leave us? It leaves us aiming for innovations that are universal in nature, that focus on delivery of high quality care and are delivered in a way that's at low or no cost to beneficiaries. In effect, it leaves us yearning for innovations that subscribe to universal health coverage principles. That's the UHC cube here. So in any innovation that we would expect, we would likely see something that has an element, an approach of self-care. We hear a lot about self-care. And self-care, if you stop to think about it for a moment, is really person-initiated or individual-initiated rights-based care. It's individuals seeking resources. It's individuals using resources from the health system to achieve a desired health state, to make progress on a health journey. I hear that often. I hear this term self-care, and I realize it has to be more than the patient healing themselves, right? That it's the individual taking charge of their health journey. And it's the individual, as this triangle here indicates, cutting across in many ways the health system and using resources, engaging with specialists, using health system resources to achieve health goals, and doing this in a way that incorporates those resources into the individual's everyday life. So it's the use of elements that we're familiar with on the supply side, but incorporating it in a way that's meaningful and important and relevant to the individual in their, his, her, our everyday lives. Where does that leave us, this community of practice, healthcare professionals, many of us, public health professionals, others? Where does that leave us? How do we understand, and how do we think of self-care as human-centered or as individual-centered, initiated care seeking? There are certainly challenges in the world as we see it. There are challenges in the way the world is now. Health educators at NGOs and other places want to engage consumers, but can't. Service providers want to see increased volumes and treat more, but can't. Health insurance funds want to expand coverage, see more policyholders, but don't. And manufacturers and others in the health system itself would love to see greater uptake of product, more use or integration or insight into consumers, but don't have that visibility. So what sort of innovation do we need to drive self-care forward from a health systems perspective? What can we do on the health system side to ensure individuals can drive their own health experience, their own health journey? I would argue it's marketplaces, that marketplaces in a well-implemented manner can help to connect consumers, can help to connect individuals on their healthcare journey. That an example I'll give here with chat-enabled marketplaces, these one-to-one chatbot experiences can do the needful. They can generate health awareness. They can generate uptake of products and services, and they can generate, as a result of this data enabled exchange, they can generate data on consumer demand, behaviors, and insights that can further accelerate access and expand access to family planning, filling in those nooks and crannies, if you will, that the panel is predicated on that we're convening here today. So my call to action and the innovation I see happening here is really this focus on reorienting health systems and the resources in the health systems in such a way that we can unlock through marketplaces the ability to educate, to generate referrals and feedback on those referrals, and ultimately generate insights from consumer interaction with the various stakeholders in the health system. These one-to-one chat-enabled marketplaces, one example that comes to mind is Nivi, but there are many other examples of chatbot messaging solutions that are playing this critical role that fills in the spaces in between, that reaches individuals that have been underserved by the existing health system and serves them when they are most in need, when it's most relevant, when they're looking for a solution. They can find it at the tip of their fingers through their phone, and it allows them really to drive their own health journey. There may be prompts, nudges, behavioral insights, and behavioral science that drives some of that exchange or some of that interplay. But the idea is this intermediation, this ability to play a connective role between the health system and the health consumer. Marketplaces will fill in on the demand side what so much distribution and supply side intermediation is done to connect and stitch together the health system. Marketplaces will be the demand side analog that drive forward our ability to connect ultimately populations and individuals to the health system and the health services that everyone needs. Thank you.
Thanks, Ben, and thanks for some great graphics that help to make it very clear, this model of a marketplace and how it might work. I'm really glad that you raised some points also about self-care, and I like the caveat that it's more than the patient healing themselves, but appreciate this focus on sort of also empowering users of those health services to be able to connect to and access the information they need. We know that self-care is important for improving the overall trust in the health system, the quality and equity of care, health outcomes, experience of care. So it's really great to hear that come up in the conversation today. I'm sure there will also be many questions about this engagement with marketplaces and the tools that Nivi and others provide. I think we still unfortunately have not been able to have Dr. Frey from the Government of India connect with us. So we'll move on to a bit of discussion for the panel. And if she's able to join us a little bit later, we'll come back to her on that point. I wanted to ask, to kind of open this up to all of the panel, you know, the focus today is moving from the sort of policy passage piece, right, that we talked about in the first session into policy implementation. And I think therein lies the rub. That's often the challenge in taking the policies or the schemes, the design of health financing or UHC approaches and actually turning them into increased access to affordable and quality services. So I'd like to, I may go back in order in which those of you spoke. I wonder, Dr. Kaba, if I could ask you from the Ministry of Health perspective to share a little bit about some of the particular challenges you have seen to the implementation of the UHC approaches that are being taken in Guinea. So that's the first question, sort of what's the biggest challenge you've seen? And then I wonder if and this will be for each of you, if you would then make one recommendation for, there's a large body of advocates, of implementers, of healthcare providers, of government officials on the call today, one recommendation for what those of us in the discussion today could do in terms of advocating for or supporting removing those barriers to policy implementation in Guinea or elsewhere. Let me start with Dr. Kaba, and then I'll turn it over to the rest of you, and then we'll start taking some of the questions from the audience that are coming in. Great to see them in the Zoom. Dr. Kaba?
Merci beaucoup de me redonner la parole à nouveau.
Thank you very much for giving me the floor once again. I would like to say that in Guinea, the most important starting point for UHC is primary healthcare. And the issues like family planning and other more specific domains are a secondary level. So the panelists who spoke about innovations recently, I don't know that this is a truly unique model. I think that a large part of women need to have more access to family planning and other services. This is a significant challenge. There are girls and women living in the most isolated areas. And I know that the speaker recently talked about using new technologies to increase access to information and to increase the ability to request services and also to encourage more self-care. And so this is a way that we can also increase the supply of certain methods at the community level. So the challenge is, how can we use digital tools today to make sure that women can access the information that they need about family planning? We know that telephones are used very widely today, even at the community level and in more isolated areas. So how can the information that we have, how can it be transmitted in language that is accessible to people at this level? How can we make sure that even the most marginalized populations have access to this information? We need to make sure that people are able to access this information in their local languages. I think that this is a significant challenge, but it is not one that we cannot overcome today. We need to translate all of this information. Of course, this might require a bit more effort on our part. In Guinea, for us, there is not one simple approach. We are using several approaches. We have workers who are working in different institutions and institutes at the national level. We have workers who are covered by insurance. We have national insurance. We also have a strategy for care and for different ministries to participate so that they can make sure that all the members of the population have access to quality healthcare, including family planning services. So we need to create good synergy and good partnerships between the different approaches so that we can make sure that this care is accessible to all members of the population. And we need to make sure too that it is affordable for families. And I think that that is one of the most significant challenges. And something that is important for all approaches, all different initiatives, and all innovations. We need to make sure that beneficiaries have access to different services and that we break down the financial barriers that can hinder their access to these services. It will require effort on the part of the government. It will require resource mobilization, specifically for financing UHC and family planning. So if we want to make sure that this is a sustainable change. Thank you.
Thanks, Dr. Kaba. Thanks again for covering many and connecting to many of the points made by the other panelists in your comments. And I particularly appreciate the focus again on reaching those who may be outside of national insurance structures, focusing also on the sort of community awareness and reaching communities and thinking about which innovations are accessible to various parts of the population, including linguistically or for those with low literacy or different access challenges. Maybe picking up on what she was talking about related to some of the insurance and financing. We're starting to have quite a few questions coming in for the panelists, so I may move to those and encourage you to respond to each other. I wonder, Matt, sort of reflecting on what Dr. Kaba was saying, if you'd like to come in a bit on some of those financing pieces. There's some specific questions that the audience is interested in terms of how you talked about a couple of countries already in your examples from the work you've been doing at ThinkWell. There was a general question about which countries have been able to successfully integrate FP services into existing health insurance systems, but maybe you can talk more broadly about success in getting family planning into those health benefits packages, regardless of how they're financed, or, you know, there are just some sort of continued general interest in how you may leverage those financing approaches you talked about for family planning.
Thanks, Amy. Yeah, let me come to. I'd like just to follow up a little bit on some of the questions raised, actually, in both of the previous presentations. Then I'll come back if I can to try and speak specifically about the financing. Hopefully this links the things together, but there is a thing that we talk about strategic purchasing. It means different things to different people, but the broad definition of making purchasing more strategic, improving the way that we spend money on critical services, is that the money is directed where it is most needed, based on information that is coming back from the system. And one of the things that I feel we are on the verge of is creating a virtuous circle between data and financing. Historically, it's been quite difficult to direct funds where they're most needed, purely because ministries of health, national health insurance agencies, other purchasers of services often don't know where that is, and so budgets just get written and money goes out where it went the year before, plus or minus 10%. When we look at the potential of information systems to feed better information back and to link the money going out to data information coming back, that virtuous circle can kick into place if we don't start at too ambitious a place. If we can look at the basic information that is coming back through health systems and reward facilities providers for supplying that information by linking it to the resources that are allocated to them, that will encourage more people to feed back that information, and it will allow us to refine our systems to drive funding for the services and for the people that we care most about. So I felt that was coming through from the Guinea example and also from Ben's point. And I hope that in the next few years, we will see that starting to really make a difference in health systems. Family planning into benefits packages. Yeah, in many countries, family planning is included in benefits packages, but not always in a way that has been effective in improving access to family planning services or the quality of the services. Kenya is a good example. Family planning has always been in super cover, which is now part of the Afia Care scheme that is being rolled out to 1 million poor households at the moment. It's great, but it's funded through a capitation payment. So it means that there is no incentive to a provider to offer those services. There's no additional payment. It's just assumed to be covered. And I think what we've seen over the last 5 years or more is that for many people, the notional coverage of family planning in that package has not led to improved access. And in fact, in many cases, you might be able to get pills or condoms from your provider without having to pay for them, but you're unlikely to be able to get a long-acting reversible method, for example. In theory, you can, but in practice, it doesn't work very well. In other countries, we've seen the opportunity to expand access for those people who struggle to pay for services by engaging with private sector providers. I think the Philippines has made significant efforts to that, as has Indonesia. Both cover family planning services, and both systems offer a payment for long-acting and reversibles and for permanent methods on top of a capitation payment. So they incentivize providers to offer those services, and they have had some success, although I'd say it's limited, in engaging not only public sector service providers, but also private providers to offer a greater range of family planning services. So I think there are still opportunities there. I hope that goes some way to answering your question. Amy, there's a lot more to say, obviously.
Yeah, I think so. And Matt, just before I pass it back to Ben, you know, when you were talking about that virtuous circle and the almost sort of incentivizing the sharing of the data, you know, we'd been hoping that Dr. Frey, if she was able to join us, was going to talk both about sort of public and private sector providers. And I wonder if you can comment a bit on, I think because so many people access family planning within the private sector context, that challenge of ensuring, I think what you were talking about, the data to inform how we manage those health services is one thing. If it's coming from the public sector, can be quite a challenge to think about how we have that. I just wonder if you want to talk a little bit about working, since we don't have her, with the private sector in that space.
Well, yeah, and of course, one of the great advantages of a health insurance type financing model is that very often health insurance agencies are better suited to contracting with private providers than you know, the ministries of health. They're just, you know, their governance structures enable that. And one of the terms of the bargain between a purchaser like a health insurance agency and a private sector provider often revolve around that exchange of information. So if you submit records, claims for the services you provide, then we can reimburse you for some of the cost of that service. And so again, you know, that potential virtuous circle can begin to be established. Very often the challenge, there are many challenges around trust and engagement between private providers and government agencies, and ensuring that payment is timely and is adequate to cover the real costs of those services is often fundamental to that. But again, the ability to automate some of those systems and to guarantee rapid payment, I think, can fundamentally change that balance and will encourage more private providers to engage with public financing. The objective is not to make sure that everybody can choose between a public provider and a private provider. I think the objective is that in many situations, actually, private providers offer critical services to poor populations. The urban poor often rely on private providers, for example. And if we can subsidize those services through health financing approaches, then we can increase the choice and the quality of the services that those people can access through the private sector. I think that's really important.
Yeah, absolutely. Thank you. And that addresses the point I was trying to get at in terms of where people are accessing the service and how often those out-of-pocket payments are falling specifically on those that are seeking the services from the private sector and unable to access that reimbursement. So thanks for explaining that quite clearly. Ben, your presentation sparked lots of questions, both about the self-care piece and about the marketplace model. So I might ask you one of each. There's one here sort of touching on the political and the policy piece. So I want to get to that since that's partly what our discussion today is about. Someone was raising the question to say, you know, it's interesting to see the important role of self-care in universal health coverage. How do you see its integration into different levels of the health system, especially at the level of political dialogue at the national level? What is at stake? Not an easy question, but love to hear your thoughts on that.
But this is why we're here. Take hard questions. No, thank you, and I appreciate everyone's engagement today. I would first say there's an idea here, a principle that we can take from sport. In football, you run to where the ball will be, not where it is right now. And I think in much of family planning, we are anticipating this greater domestic resource mobilization requirement, maybe an opportunity, that the emerging markets and emerging economies require in some ways greater reliance on private sector for achieving those family planning, those public health goals we collectively share in this community of practice. And so investment seeks a return. And then there was a question earlier about what kinds of investments do we expect in marketplaces. Investments seek a return, but I think that we need to, and as such, we want to see marketplaces that can offer a return, that can generate a return on those investments. But we also want to see marketplaces that can generate social and public health impact. I would argue the two are not mutually exclusive. In fact, there's a lot of synergy and potential to align incentives, capital incentives, and social incentives or public health incentives in a way that returns value to the public health system and to the private sector that's catalyzing further change for the public health system. So what needs to happen on the political side? We need regulatory environments that see the view favorably, the opportunity to do digital counseling, that there's value, there's social value, there's public health value, and there ought to be a financial value in educating populations. Every Ministry of Health has an Office of Health Promotion, but how many of those offices of health promotion now engage or utilize chat, for instance, as a way to advance their public health messaging? They should. Why not? Any company selling or marketing its products in emerging markets, or any market, frankly, globally, uses ad tech approaches to selling its services and products these days. I would argue the same ought to be true for ministries of health. Simply buy in. Why build a chatbot when you can buy? That's ultimately the question I think many of us ought to ask ourselves today. Thinking about the context in which marketplaces are being rolled out, recognizing that there's a financial investment and return opportunity, that there's a private sector play for public health objectives, and that there are business models that can stimulate or catalyze this. We call them B2B2C, that is business to consumer. You don't have to charge the end user for a service that they're receiving if the businesses benefiting from the marketplace are paying in to that marketplace. And that's precisely the approach we've taken at NIVI, and I've seen other businesses do in emerging markets. this idea of being able to offer a service for free to the consumer, because as Matt was mentioning, data is important, is a viable model when businesses can derive and governments can derive benefit from that engagement. So there is a virtuous cycle here of further capital investment that can be catalyzed by using marketplace models to serve various market segments in the regions in which family planning services are still in high demand and under-delivered.
Thanks, and great job, Ben, answering multiple questions that have come in for you in one session. That's great. Thanks very much. I want to return to Dr. Kaba. Actually, all of you may have perspectives on this one, but I'll ask her to start. There is a particular question about the need for access to family planning for adolescents and young people, which I really do want to lift up here in this session. And the question is regarding the fact that many young people may be left out of financing models, of health insurance schemes, of UHC, of access to universal health coverage type services, partly because of their age. It may be that they are not in the formal sector, they themselves are not employed, they rely on their parents for accessing health care, they don't have the resources to pay out of pocket for family planning in the private sector. And so there's a question about health financing models targeting adolescents that have worked. The commenter is saying that the Linda Mama in Kenya is a great opportunity, but not very adolescent friendly. So I wonder, Dr. Kaba, whether in Guinea there have been particular steps taken by the government to address this this challenge of lack of access of adolescents to being covered by some of these UHC financing schemes, or other work in particular that your government has prioritized to increase access for adolescents to family planning. Please turn your video on while you're speaking. Thank you.
Ok, merci beaucoup pour la question. Je pense que
Thank you for this question. I think the issue of access for youth to family planning services is a reality that needs to be taken into account by the government and the different political programs and family planning programs. As you well know, if we really want to improve today the prevalence of contraceptive use in our countries, we need to give young people access to family planning services in their demographic group. Sometimes up to 50% of the young people do not have access to family planning services. In Guinea, we are fully aware, which is why with the new and commitments that were made, one of them has to do with the free access of youth and adolescents to a family planning service. We based ourselves quite a lot on the Burkina Faso experience, which has tremendously increased access to free family planning services for young people. Our perspective is that we've committed to increase financing, because since 2018, 50% of the needs for family planning are financed by the national development budget. And in order to reach this level of free services, we've made another arrangement, which is to increase up by 10% every year. So the challenge is to respect our commitments, to keep those promises, and discussions are underway. By the end of the year, we should be able to organize a study trip to Burkina Faso to discuss in depth the issue of free services, because we're already in a context of free services for some services, but it has it is already raising a lot of issues in their implementation. So we need to reach a level of free services so that the young people in the Sahel can have access to family planning services, basing ourselves on the lessons drawn from those countries that have already managed to do so in the area, and build up on their experience in order for us to launch more efforts towards free services. This is one of our perspectives. This is one of the commitments we've made, and we will do everything we can to keep those commitments, because it is important for young and people and adolescent people to have access to family planning services of quality. We know that the financial obstacle is preventing the services from being from having access. So, and when we organize those seminars, we have it's so many young people who come to attend. The financial obstacle is a true barrier to the use of those services. Thank you.
Thank you, Dr. Kaba, and great to hear both about Guinea's commitment to providing access to young people, as well as this opportunity for sort of cross-country policy exchange and learning. Terrific to hear about building on that model. Matt, I think you mentioned that Burkina Faso is one of the countries where your colleagues are working as well. I don't know if you want to come in and make a comment on this, please.
Yeah, and my colleague, Dr. Fosse, our country director in Burkina, I believe is on the call and will hopefully be at ICFP as well. So Dr. Kaba, you're very welcome. I think we have some presentations at ICFP about the experience of family planning gratuité on Burkina Faso. So it will be wonderful to exchange thoughts on that. I also wanted to thank the questioners about adolescent girls. I think this is such a critical issue, and I think it is one of those areas where asking that question about who can benefit from a particular health financing approach is really critical. There are, I think, significant challenges in using a sort of health insurance type approach for family planning in reaching adolescent girls. If, for example, you issue an insurance ID card to the head of a household, and there is a young girl, an adolescent girl within that household, I think it could be challenging for her to to use that ID card, that family membership of your health insurance scheme, Afia Care in Kenya as an example, in order to access any kind of sexual and reproductive health services. I think in some particular contexts, that challenge is amplified. I'm thinking particularly of Indonesia, where JKN, the national insurance scheme, does cover family planning and has very high population coverage. But Indonesia has a particular profile of family planning with actually stagnating MCPR, reduced uptake of modern contraception, particularly among the wealthiest urban quintiles, and particularly amongst unmarried young women who find it very difficult to access services. I think there is a case to say that a different solution might be more appropriate than extensive promotion of family planning through JKN to reach those population segments. And I suspect that Ben will come in and say that digital solutions for counseling and referral would be a very good fit for that kind of challenge. So again, if you start from the question of like, who's going to benefit, who's this this approach to financing most likely to reach, I think taking the perspective of an adolescent girl is a really critical approach.
Thanks, Matt. Yeah, and Ben, Matt already teed up the question. Love to hear your particular, maybe there are experiences where this, the use of the marketplace has been particularly relevant for adolescent populations.
I'd say we've consistently reached young people 15 years and above on the NIVI platform. It's been a smaller segment of our overall user base, 15 to 17, under minors. But then when we look at, say, family planning services in Nigeria, NIVI served more than 65,000 users through WhatsApp at this point in Nigeria. We launched December of 2020. So we're in 3 countries. We're in Kenya, India, and Nigeria. Kind of skipped around the map there. In Nigeria, our most recent country, we launched in December 2020. We now have 65,000 users who have found health information, digital counseling, referrals on the chatbot. Now, we've also partnered, and this is critical, on the business side, on the organizational side. We've had 3 initial partnerships, FHI, Society for Family Health, SFH critically, and Pathfinder on a maternal health scheme. So we've partnered with 3 organizations, and we're looking for others. And as this grows, we're able to make referrals to more parts, more regions in the country. And so this allows us to cover more of that adolescent population and others who are in need of the service. Now, I don't mean to oversell the service. I want to be cognizant of the fact that disproportionately, we are reaching people who are on WhatsApp. In Nigeria, those are people who have phones. It is not going to be the most underserved. However, where we are today means that we can be in the market tomorrow, and that the opportunity to subsidize more efficiently through a digital platform exists. That the means to reach, the tools are there, are being built, deployed, made available to more and more organizations that want to reach the populations that we're in touch with and expand our reach. That ability, that capability is now dynamically available in places like Nigeria and Kenya and India. So to the earlier question, not only about adolescents, but how do we know this works? There's 2 ways to think about it. One, in terms of efficiency. Are you getting more output for every financial input into the system or resource input into the system? So there's an efficiency argument, and there's an impact argument. In the absence, if contrary to fact this did not exist, would you have a similar level of impact on a given population or a given health outcome? And so those questions you can test. We're running an RCT, a randomized control trial in India currently, in Indore and Bhopal urban markets, looking to see what the effect is, the additionality of a digital counseling solution, NIVI, in family planning uptake and method continuation. So I think there are certainly ways you can look at recurrent, kind of your operational questions around efficiency, and the sort of scientific or experimental question of impact to determine value. But I think our day-to-day, the fact that we've reached 65,000 in Nigeria, we've reached more than 500,000 accounts in Kenya, and about 1.2 million accounts in India so far. Now, these are light touch events, a little bit more engaging than, say, an impression that you have on a web page. This is somebody now reaching to the chat, but we can deepen that engagement, and we can re-engage individuals in a way over time that you can't with a web page, for instance. And that it's, in the analog world, in real life, would require sending the ASHA or the community health volunteer back to that household for another follow-up conversation. Now it can be done through a phone. There are limitations. You need to have phones, but we can reach more and more user segments. So in addition to adolescents, I think there's another unobserved market segmentation or market segment here. People who have low readiness to act. There are certain unobservables in the marketplace that we don't speak about because we can't measure it. We talk a lot about adolescents or maybe the poorer segments of the population, but there are individuals across society that have a need, but an unexplained low readiness to take or act on family planning. And that ability to now measure or ask someone as they get into NIVI or into another chat experience, how likely are you to act on this? And if not, why not? Allows for an immediate response. We can say, oh, all right, there's a financial barrier, or there's some other information that would help motivate, or there's questions simply around prioritizing the experience and the need for family planning that can be addressed through chat. And so by identifying individuals with low readiness, we then look to understand or motivate, help unlock the inherent and the intrinsic motivation that someone may have. I see Martha's comment on ambivalence. It's an important aspect to measure. So I'll leave it there. Thanks.
Yeah, thanks, Ben. On ambivalence, or also, I think, how are we tracking this sort of cultural and other structural barriers that contribute to lack of readiness to try to overcome, to address the barriers and the challenges that it takes to access family planning in some cases. So we're getting close to the end of the session. I'm going to do one more short round of questions, and then we'll head into our closing remarks. I wanted to ask Dr. Kaba, there's a comment from someone based in Ethiopia who said that in their country, Ethiopia is currently using the maternal health service free of charge approach, so free services, but the community uptake for the services is still low. And I think you importantly in your beginning comments talked about community level access. The person writing the question said, I think we missed the innovation strategies and appreciate what the presenters have been sharing. Are there some strategies in particular that you might propose in addressing this low uptake, even when some of the financial barriers have been removed? Some of that gets into what Ben was just talking about, but I wondered if there was anything you wanted to share from the Ghanaian context in terms of community mobilization and education to use the services. And please put your video on while you're speaking.
Okay, merci beaucoup pour la question.
Thank you very much for this question. I think that in order to get the community to accept what we are proposing as services, whether preventive or otherwise, I think that it is important to have a dialogue with the community. The community needs to be a stakeholder in every initiative. And for every initiative that we are planning for their region, we need to develop these initiatives with their participation so that we have a better understanding of their needs and their desires. In working with the civil society and other leaders, we need to make sure that members of the community are our allies so that we can work together and work with the different health workers when we are implementing any initiative, when we are seeking behavioral change. Because if certain behaviors make it that certain services are not used, we need to change this. So we need to make sure that the community is involved from the very beginning in order to ensure adhesion, in order to ensure uptake of these services. Thank you.
Thank you, and thanks for putting the emphasis on the engagement of the stakeholders in how the policy is being shaped, how the programs are being designed to meet their needs, or maybe not meeting their needs, as the case may be. There's a question either of you, I think, could well, maybe I'll go to Matt. There's a question related to coverage for commodities. I think we have heard in the comments so far the importance of method choice, the importance of availability, and the challenges of how different financing approaches may provide broader or more limited access to commodities. I wonder if you could talk a little bit about financing approaches in particular for ensuring that range of choices are available.
Yeah, that's a great question, as indeed really is the question of financing for promotion and for BCC. efforts. These are things that are not as obviously a fit for health insurance kind of output-based approaches to financing. I suspect that paying for promotion services is something that will logically stay with stay with Ministry of Health, stay with the family planning unit in the Ministry of Health or whatever as a budget line finance, and will continue, I hope, to be supported by donors and other partners. I find it quite hard to imagine a situation where a National Health Insurance Agency invests heavily in that. The cost of commodities, particularly contraceptives, is equally challenging, and there are a number of different models out there, including some where those costs are actually transferred to facility level or to district level as part of a claim, and then part of a reimbursement for services, and then the responsibility sits with that local government entity to purchase commodities, sometimes on the open market, sometimes from a central medical store that runs the procurement separately. I think it's much more common for procurement and supply to be centrally managed and centrally controlled, so that the cost sits with a central medical stores, a KEMSA or equivalent, which then distributes the commodities out to various players. I think there are opportunities for more effective engagement with the private sector through the utilization of subsidized commodities. And I think in some countries where a formal contract between an insurance agency or a government agency and a private provider is problematic, there are deals to be struck whereby, in return for that information that we've been talking about, in return for reporting and in return for following national guidelines about quality and choice, private providers can avail themselves of subsidized commodities. And I think that's a relatively kind of straightforward deal. It doesn't involve cash going backwards and forwards. So that, I think, is an entry point in some cases. I have to say that financing for contraceptives is extremely complicated, and I think something that probably those of us who work in this sort of area, and my colleagues, I was speaking to colleagues in Kenya this morning about exactly that question. Can we figure out really what's going on, and are there opportunities to make it better?
Thanks, Matt. Ben, in the interest of time, do you want to add anything on this sort of contracting question before we move on to closing comments?
Well, just real quickly, Joe Keating had a radical question. If we could, with limited resources, how do we balance choice for long versus short-acting methods, for instance? And I would, to play a bit off Matt's comments in contracting, pay for what you want, pay for the outcome desired here, the desired outcome, and so pay for choice. And what does it mean to pay for choice? You could pay for informed choice, pay for facilities that could demonstrate that patients and clients are leaving well informed. And now in a more and more digital enabled environment and ecosystems, it's possible to ask consumers these questions in a way that would have been logistically challenging in an analog world. So I'd say pay for the world that we want, not the world that we've got. Thank you.
Thanks. That was a perfect, succinct answer to a very to a challenging question. Thanks, Ben. So I want to now, I'll have some time to thank and acknowledge the panelists at the end, but I want to invite Nabiha Kazi-Hutchins, who's the president and CEO of PAI, to join us to give some closing remarks. I know there are so many good questions in the chat. This conversation could have gone on all day, but we're looking forward to hearing from you, Nabiha. Over to you.
Thank you so much, Amy, and thank you to all of our amazing panel speakers for sharing your insights on what's really needed to implement a UHC agenda that, of course, centers on and prioritizes family planning. I lead PAI, and we're very honored to host this very important dialogue and conversation alongside FP 2030, Knowledge Success, and MSH. As many of you know, PAI is a civil society organization and one of the leading advocacy organizations that is championing universal sexual and reproductive health and rights. For the past 57 years, we've been advocating to our own government in the US and on the global stage to ensure that our policies, our investments, and our programs are expansive and supportive of women, youth, and at-risk communities around the world. And in addition, we're very committed to expanding and supporting an expansive civil society space where we are providing approximately 120 community-based civil society organizations in over 35 countries with flexible funding and technical strategic support so they can achieve their own aspirations within their own context, advocating to their own governments and stakeholders. At PAI, our mission is very clear. It's bold, but it's clear. It's to achieve universal access to comprehensive sexual and reproductive health and rights for all. And of course, as we all agree on this call, family planning and contraceptive access is really core to achieving comprehensive care and services. And the pathway to achieve that and to achieve universal access to care and services, which of course are meant to reach every person, is through universal health coverage. So this issue and this conversation is not only something that we are committed to programmatically, but is very much part of our core mission as an organization. We are steadfast in advocating for the inclusion of family planning and contraceptive access as part of UHC. As I mentioned, it's not only essential healthcare, but it's also essential for us to achieve because this has an impact if we are going to achieve the gains across health equity, economic empowerment, gender equality, educational attainment, and so much more. What was striking from today's conversation really was the diversity of issues and the opportunities to better enable sustained family planning services that are integrated into UHC. And for me, really what stood out, ensuring the right policies are in place to guarantee access, that there be sustained financing and investment in health systems and delivery of commodities and care, and where that care is of quality and where it's delivered in a compassionate, dignified, and inclusive manner. It's not just important to deliver services and provide those commodities, but the treatment of people also matters in this equation. The third is that we really prioritize community-based efforts to drive awareness of and demand for services and approaching that through a rights-based lens. And the other piece that really stood out is the recognition of the role of civil society advocates, of researchers, of providers, of private sector, and of government officials, all working together to advance these priorities in really complementary and coordinated manners. And as one of the speakers noted, theory cannot be one thing and practice cannot be another. They really must be one and the same. I share this because it's across all of these areas that PAI is not only grounding its advocacy, but also supporting peer civil society organizations who are taking on these priorities to advance family planning. One of the examples to lift up for you is PAI's efforts through a collaboration with local civil society organizations and youth organizations, which is our Universal Health Coverage Engage initiative. And this initiative really supports local CSOs in Burkina Faso, Ethiopia, India, Kenya, Nigeria, and Uganda with the tools they need to advocate for the prioritization of sexual and reproductive health and rights in country level universal health coverage policy reforms. The investment here, and this goes back to my previous point, is multifaceted. It's accountability efforts, it's policy advocacy investment, and it's also, of course, the other side of the equation, the demand and right side of it. So community education and awareness. And I share this because all of our investments are very much focused, and collaborations are focused on this holistic, comprehensive approach. And we, along with our UHC partners, are gearing up for ICFP and the very ambitious and exciting goals there. You'll meet our partners from Kenya, Kisumu Medical and Education Trust, and PPI. They're developing a robust evidence-based accountability mechanism that involves CSO coalitions and focuses on community leadership at the country level to monitor progress for FP and UHC. In Burkina Faso, our partner ONIDS has been selecting young social media influencers. So again, amplifying and communicating influencers and advocates as champions for family planning in each country to raise awareness and inform communities of their rights and what services are available to them. In Nigeria, we have our partner, the Africa Health Budget Network, that is really adding a UHC lens to its family planning accountability capabilities, really analyzing those health budgets and benefits packages and make sure they're meeting the needs of communities. And last but not least, our partner in India, Sahayog, has been tracking the grievance redressal system under the National Health Insurance Scheme. They're also documenting cases where rights have been violated, where there's been negligence, overcharging, et cetera. So all of this just to give you a snapshot of where we are. And the last few things I just wanted to share with you is that certainly, as was noted earlier, all of this conversation provides important content to inform a draft policy paper with the intention of having a final draft for validation for family planning advocates at the International Conference on Family Planning. We hope each of you will stay engaged in future conversations and those feedback mechanisms to ensure that policy paper is reflective of what the needs and urgencies are. And you can go even further. You can go further by becoming an FP 2030 commitment maker. Each commitment maker has pledged to take specific actions to increase the use of voluntary rights-based contraceptive worldwide. And PAI is in the process of finalizing our own commitment, which we'll be ready to share at ICFP in Thailand. And we welcome you to join us, either by recommitting or by making a new commitment for those who would be doing it for the first time, really advancing family planning priorities in your own country, in your own community, in your workplace. By making this commitment, you're really going to be part of this global collective of efforts and actions to advance family planning through UHC and ensuring that there's sustained investment so services are accessible and never denied. I want to thank all of the panelists. It's been a great pleasure to be part of this conversation, and so much that, of course, I have learned, and I'm sure everyone else has learned, and maybe continue to work together in collaboration, bringing diversity of voices, perspectives, and experiences to achieve what we ultimately want, which is universal access to family planning, that it not be denied for anyone, and that be centered on rights, on data, on evidence, and a commitment to making people's lives better. Over to you, Amy.
Thanks, Nabiha. Thank you. Very well said. And thanks for the reminder about the importance of making FP 2030 commitments. I want to mention for all of you in the chat box, our panelists are sharing resources, our organizers are sharing resources, so encourage you to click on those. I want to share a big thanks. I think you'll agree this has been a fantastic panel, fantastic discussion, and great engagement from the participants. So thank you very much to Dr. Kaba, to Matt, to Ben, to Nabiha. I do want to mention here on the screen, you'll see the next dialogue focused on the demand side and on leaving no one behind will take place on October 18th. We hope you'll join us for it. If you were on the list and signed up today, don't worry, we'll be sending you reminders. We'll also be sharing shortly the recording and the slides, the presentation some of you have been requesting. We do also look forward to meeting many of you in person at the International Conference on Family Planning in Thailand. Our team behind the scenes, I really want to thank all the folks that it takes to make such a seamless webinar happen. They're also promoting and sharing messages from this event on Twitter, LinkedIn, other social media platforms. So please join us in amplifying the messages that you heard today. And I also especially want to thank our interpreters. I know that all of us advocates can be quite enthusiastic and quick in our way of speaking. So thank you for being there and making sure that everyone could participate. Thanks again to the co-hosting organizations, to FP 2030, Knowledge Success, PAI, and on behalf of us at Management Sciences for Health and the Civil Society Engagement Mechanism, thank you all for your commitment to increasing access to family planning, to achieving universal health coverage. We look forward to continuing to advocate together with you. Thanks so much and have a good rest of your day.